is we go around, you know, everybody gets to pick something up, and we'll
like
go.
the questions.
Right, so you pick something up, so all this stuff, you have all kinds of stuff. So all this stuff is fair game, right? So you've got boxes of stuff over here, you've got all kinds of stuff, right? Right, so all kinds of stuff over here, some pediatric stuff. Any more stuff over there? Like I said, there's boxes, so what you do is pick something up, and I'll do my best to tell you what it is and what it does. Right, so I think, you know, we go around the room, everybody gets to pick. So if they already know what it does, right? So like, you know, everybody probably knows what this is. We've talked about it at length, or this one, right? So, you know, if it's something you already know, let's not go there. Let's talk about the things that you don't know, perhaps.
Okay.
What is this?
Huh? This is a pickup, or it's actually a needle driver. So they put a needle in there and they'll take it. So the thing about it is you can put a needle. What are you looking at?
I was just talking to Zach before, and I thought the only thing it could be would be a tweezers or something that the surgeon would use to sew.
Yeah, it's a needle driver. It's called a needle driver. And see, it has a little locking mechanism. So you put that in there and you lock it, and then you can use it to sew and whatnot. Right, so we'll put this by the surgical instrument.
How would that be a tool for us to notice as a perfusionist versus the tool for the surgeon?
So, okay, so you guys heard me say with both James and being here that we've added, right? We've added surgical awareness to your assessment tool, your assessment instrument, right?
Mm-hmm.
So this is unique from any other perfusion school. This is next level stuff, right? And so that's why we have some surgical instruments. That's why we're having Dr. Reddy come over for your A&P class and talk to you about cannulation, talk to you about the surgical procedures. So we're gonna have a scrub tech come over and talk to you guys, or a first assistant to talk to you about, you know, the surgical aspects, right? Things that I'm weak on, right? I can tell you this, if I go someplace and I can see the case, I can watch the case. They have what's called a surgical cam. If I do that, I'm happy, right? Because I can stay ahead of the surgeon if I can see what they're doing. Most of the time you can't. Most of the time you can't. And so what you gotta do is watch when they reach for something. Watch when they pick something up, or watch when they ask for something. That'll give you an indication, right? So if they ask for 2-O-Proline, they're probably putting in purse string sutures, right? And so if they ask for a Ramel, that's what they're doing, is putting in purse string sutures, right? And so having a surgical awareness for a student is a big deal. It's a big deal, but it's gonna put you on a different level, right? It's gonna put you on a different level of understanding, right? And so we're teasing it in here. We're trialing it out with the third cohort because they're a good group. You guys are a good group, right? But you know, so when we did this exam with them, there was no surgical instruments. So this is something that Professor Evans and I, and Al Stammers, us three, this is what we've postulated to separate this program from all others. And it will, it's a game changer. Like, people don't talk about the surgery, even though part of your scope of practice is surgical assisting. Some perfusionists take vein and things like that, right? It's part of our practice, but there's so much to know with limited time, right? And so they brush over it. We're not gonna. So I bought a whole cardiac tray. So I've got some more up in my office. I don't know how these ended up here, but I don't know if the students, I don't know, but they're here, and if I can answer it, then I will. If I can't, I'll say I don't know. What did B say? What is this?
Toys R Us clamps is what I
Yeah, those are his clamps.
This is a tubing clamp. That's a tubing clamp. That's a disposable tubing clamp. What is that used for? To clamp tubing. Serious, right? So
We clamped our
ET
ET
tubes,
tubes
we didn't
so
have
that it
the-
didn't damage them.
Yeah,
right, so we
Yeah.
we try not to have to use those. I'd rather use a cricket clamp
Yeah.
than that thing. So
Okay. Oh, so is it the same as this, just smaller?
it's exactly
Oh.
the same.
Okay, it's the same size as this too?
Probably.
Yeah, they're all the same.
So this is called all of these are called, it's called a multiple perfusion set. So if we took and hook the cardioplegia line here, that's what their cardioplegia line goes. So their cardioplegia line right here. So when we do please, so at the table they're gonna hook this up like this, right? So this one might go to antegrade, right? This one, right, might go to a retrograde. These two, they might go to, you put on some saphenous vein cannula, heavily saphenous vein cannula, right? So that's a saphenous vein cannula, right? And so this will screw onto the end, right? And then they'll attach that to the conduit, and then they'll have you flow down a graft. And so we're gonna learn about that. That's a way of giving cardioplegia. So I don't know when is our cardioplegia lecture, myocardial preservation. Right, and so that's a technique, right? So we talked about antegrade. This is antegrade, right? But a lot of surgeons do it, you flow low, right? And it's so the surgeon can, oh, I see this, I'm gonna put in this last suture, it de-airs. It'll tell the surgeon, if that graft is, the location, is it proximal to the lesion? It happens, right? Or is it distal? Right? So if it's proximal, you can't flow down it, right? So they're gonna have to redo it. So it's a common practice for, a surgeon to do that. This is also called, it's also called turkey foot. It's also called the Medusa. It's also called, what else have I heard this thing called? Octopus.
Are those all acceptable terms on the test?
If you use one of them, I'll go with it, but it's called a multiple perfusion set. Let's see what the company calls it. Oh, cardioplegia set. So I would call that a multiple perfusion set, but if you said it's a cardioplegia set, I showed you where the cardioplegia line goes, right? But you will hear it called turkey foot, you will hear it called Medusa, you hear it called octopus. And so if I know like the slang for some of these things, I'll tell you, because I want you to be aware when you go out clinically of some words that you'll get exposed to, right? So this portion of the course is teach you vernacular. I'll try to say it properly as best I can. Please extend some grace.
how about these guys?
Okay. So this is a quick prime set, right? And so there's a little button here.
Quick time what?
So,
Quick prime. This is a
Oh,
quick prime
oh,
set,
okay.
right?
Quick prime.
It's a quick connect. This is called a quick connect, but it's for quickly priming something, right? So you don't need a connector. This is a quick connect. It's called a quick connect. And what's it used for? To assemble some pieces of tubing rapidly. Right? That's all it is. Right? So you see there, go together and it doesn't come apart. Right? Everybody see that? It's just a quick connect. Right? So I'd love to have these on all the pumps, but why do you think they may not have these everywhere?
Expensive, unnecessary.
That's exactly right. They are expensive. So they do put them in this disposable, right? cardio help, right? But this disposable is probably, I don't know, $10,000, $20,000, something ridiculous. And they send you these too, so don't forget your disposable clamps. This is actually called a disposable clamp. It's the name of it. So, what's it used for? Clamp tubing. So there's a bunch of other stuff over here as well.
Yeah, I wanna look
There's
in there.
stuff. Look through it, please. You know, everything's fair game. I mean, there's all kinds of stuff that there's just stuff.
Something good. It's like just finding the perfect box.
Oh, it's just another.
All right, so here we have one. So you see this one? So we talked about a bulldog. These are bulldogs, right? So they're just little. This is a bulldog. And so, okay, you want to call it, you know, a vessel clamp? Call it a vessel clamp. That'll work. It's a vessel clamp. Most people call it a bulldog. Right? It's a little bitty vessel clamp. This is used to clamp off a vessel, right? So in particular, you know, they'll put this on like the Lima. So they'll take the Lima down. Like I said, everybody gets Lima in their lab. They'll take the Lima down and they'll put a little dog on it, you know, a bulldog or a vessel clamp, right? So they'll put this on it and they'll bury it inside of the chest. And all of a sudden you'll be looking and like, where's my volume going? You look at the urine output and you don't have any. Where's all my volume? You say, doctor, you know, do we have any volume up there? You know, I'm losing all my volume. I'll get to you in a minute. Your reservoir level is just slowly going down. And then they put the pump sucker in there, you get all this volume back. And you say, can you check the bulldog? The bulldogs come off the Lima. I've had it happen. It's not good. So, yeah. Those are vessel clamps. Both of those are vessel clamps.
Pleasures.
No.
Couldn't see the package.
So this is some places when they do a graft, this is a vessel marker. It's radio opaque, right? And so, you know, they'll put this on the vessels and so they can get a flat plate x-ray and they can see where their vessels are, right? So this is just a vessel marker. I'm trying to see what they call it, but
You want me to read it?
yeah, and I can't read it.
A graft marker.
Oh, okay.
Graft marker, U-shaped style.
Right, so there's a couple of different styles out there. So it's just, you know, like I said, you can see it on the x-ray. And so it's just you know, to mark the vessel, you know, where they've done the anastomosis. Not everybody does that, but some do. Okay, Hannah, Brad.
I mean,
So
I
this
think
is
you already went over that, but
what was that?
I think you went over it, but I forgot.
So this is an osteoperfusion cannula. We do have another one. So these are two different styles of osteoperfusion cannula. So we talked about, who is that? Somebody today, they were talking about, you know, you go on pump, the patient's got AI and you give them retrograde, right? And so, you know, osteoperfusion cannula, this goes over the meatus, right? Of the opening of the coronary. This tip inserts down in the coronary, but they're both coronary osteoperfusion cannula. So both of them are, right? And so this one, it's you know, it goes on the outside of the opening of the coronaries, and you just, so these are, sometimes they call it handheld osteocannula, right? And so you're gonna hook your cardioplegia line up to here, right? up to here, and then the surgeon's gonna, they're gonna do an arterial, they're gonna open up your coronary root, right? And so they're gonna take and find the coronary, and they're gonna take and put this over the end. They're gonna say, go ahead and give some, down the left. I usually flow a little bit higher down the left than the right, and so they'll hold it there, and then, if the pressure all of a sudden drops, it's because they've moved it, they're holding it with their hand. And so imagine trying to get a surgeon to sit there and hold that for 2 minutes. It's challenging, right? So you get as much as you can, right, in, and, and listen to them, like, because they got to stop what they're doing. Right? So, all right, give me a couple minutes, and that's good. You're on the right, so they'll put this over the top, or they'll use something like this, right? And you insert that tip inside of the coronary and deliver it that way. Okay? So these are both coronary ostial cannulas, both of those. So we'll turn those over so we can look at them and hang on to them. Probably made by different companies. No, they're both Medtronic. Come, take it, Luke, take it, or more.
I don't want to step on anyone's toes. I will literally point to every single thing on here. Until
Well, pick one.
but-
Pick one. So everybody knows what the gas filter is. So we don't need to pick that one.
All right, we
This
got
thing.
one.
All right. So this particular device, right? And so, if you're giving, say, something like a bottle of albumin, right? And you want to give that bottle of albumin. So if you perforate this bottle, so if you don't have this device and you want to give like a bottle of albumin, where do you want to get the bottle of albumin? Into the what portion of the circuit? Into the cardiotomy, right? And so maybe it's 5%. You got a 250 ml bottle, a big bottle, right? 250 mLs of volume. Right? It's 5% albumin. You will learn about what albumin, how it comes. It comes 25%, 5%, right? So some people choose the bigger bottle, right? So they choose the 250. And so if you don't have a device like this, you're going to have to perforate that, right, with your quick prime set or something, a line that looks like that. You're going to have to perforate that. And in order to get that to drain, you're going to have to put a needle in there. So you got to displace that volume with air, right? And so this device does that by removing that right there, open it up. If you take and perforate that bottle, it'll displace the air, so you don't have to put a needle in it. And you got other options to give it. So you can take the top off and dump it into, put a 60C syringe on top and dump it in. There's other ways to do it, but you could also use that device. And like I said, this is just a drug delivery device. And like I said, that you open that up, and so you don't have to stick a needle in it. It'll displace the volume of air. Okay?
Okay.
Do we want to maybe take off the table what he's talked about to maybe kind of like, you know what I mean?
Yeah.
Yeah, I think we
So we did the saphenous vein cannula, right?
No, he hasn't done them, but we know what they
We
are.
did saphenous
So
vein cannula.
So you wanna skip
Take
these?
that one
I
off.
think so.
So we did the
And
marker,
this stuff?
the radial graph
Is there room over there, Luke?
What about the stuff that we know? Like,
Or take
y'all
it, right, take
good
the
with
stuff
this?
off that you know.
Yeah.
Everybody knows you got
Okay.
this.
Do you want to inherit this one?
Yeah,
We
he's
talked
talked
about
about
it today. Is
it.
everybody
The
good
heat
with that?
exchanger.
Not this.
That's an
that.
external heat exchange.
I'm just pointing with it. Also, I wasn't staring at you. I was
This
looking at your
pile
hat to
stuff?
try to figure out
I
what
don't
was
know
on
if
it.
you
That's
do.
why I was looking
Or do
at
you want to go there?
Well, I like that, yeah.
I know. I was just like I was like trying to figure it out.
Lindsay? Yes. So who's next? Was that Luke was next to you?
I don't know. Somebody over there. Somebody over here. We just keep going. They can go.
So this right here.
Jerron has to get in his seat.
All right, so this is a core knot device, right? So this device is used to like sew in a valve. So instead of putting the sutures through the annulus, so you use this device. It's right. So it's to see the valve. It's to sew in a valve.
That one automatically ties it, I thought.
It does.
It's like the fancy version.
Right. So instead of, sewing it yourself, it's one, right? It's one time, and it sews it, and right, you go to the next one, and it sews it. So this is called a core knot, and it's a suturing device to put in valves, right?
I mean, I know what this is, but some people might not know what this
So,
is.
so this is a PA catheter. So hopefully Dr. Gill will be talking to you guys about a PA catheter. So, back when, in the old days when I learned perfusion, so everyone got a PA catheter. Everyone got a PA catheter, right? And so I like when the patients have a PA catheter because that's how I train, right? And so the PA catheter gives you the ability to measure right side and left sided heart pressures. So we can measure pressures in the heart, right? And so that's a good thing, right? And so if you take in, what's going to be your best indicator of preload?
CDP.
What was that?
CDP.
Right. So if you think of all of them, right? And so if CVP is the only thing available, I'll use that. But so if you really, so your best indicators are going to be your left ventricular and diastolic pressure, right? Because we talked about that. That's when the transition from high to low takes place. Well, if you don't have that, the next best is going to be your wedge. So with this PA catheter, right, I can blow the balloon up at the tip, and it'll wedge it into the bronchus, right, into the PA, pulmonary artery, into the branches of that. And when that wedge is in there, it's called a pulmonary capillary wedge pressure. And that wedge pressure, when you wedge it, it'll be a direct reflection of the left atrium. And so so how could you measure left ventricular and diastolic pressure? You could stick a needle in the LV and measure it. So if you don't have that available and you have a PA catheter, you can do a wedge. A wedge is the best approximation of the left ventricular and diastolic pressure. If you don't have a wedge pressure available, then you're going to look at the PAD, the pulmonary arterial diastolic pressure. If you don't have a PAD available, you're going to look at your CVP, right? And so, this is kind of the progression of from best to worst. And because, they don't put a lot of, so PA catheters are really good at monitoring, volume status, right? So sometimes they'll put them in at the end of the case for, because maybe the patient's not doing great, and so to maintain their volume status post-op, right? With this catheter, it has a thermistor on it. It has, right here, right, it has a porch where you can give medications. So if you look on there, what does that one say? Like our right ventricle or
It says proximal injectate.
right,
Prox
so,
injectate.
so you got different ports where you can deliver medications on this. It does have a thermistor, so you can also measure, calculate cardiac output with this. I mean, it was developed by Dr. Swan, right? And so everybody calls it a Swan Ganz. It's a PA catheter. They just got the Kleenex, Swan Ganz did, right? And so if we go on pump, and so if we put this in, so we're gonna put it in to the right jugular vein, and that's a direct shot. If you look on your model over there, it's a direct shot directly into the heart. So they'll put it in the right jugular vein, they'll float this down. Once they get the tip down so far, based on the catheter, once they get it down into the right atrium, they'll say balloon up, you blow the balloon up, and they'll float that all the way into the PA till it wedges, right? And so, like you said, that's a reflection of your left atrial pressure, right? And so we're not really measuring left atrial pressure, we're wedging it. And so the pulmonary capillary wedge pressure, you're gonna have to know this is a reflection of the left atrial pressure. And so when we start cannulating and whatnot, they'll pull this back into the SVC, right? And then when we wanna come off pump, right? Or once they decannulate, they'll push that, float it back down. So some places, if they're putting these PA catheters or Swan Ganz or whatever, You know, they'll take in, you know, sometimes they'll get somebody to help them float it. So the anesthesia, they're gonna be sterile, right? They're gonna be gowned and gloved sterile. They're gonna have to have somebody that's not. And so this is how you blow that balloon up. So they all come with this, and so what you're gonna do is, once it gets in the right atrium, balloon up, you blow it up, and that's the same thing when they float it into the PA. And if you go, what's the wedge pressure? They just blow the balloon up, and it'll read the pressure. It's a reflection of the left atrial pressure. Does other things, tells temperature, tells cardiac output. It's got several different ports where you can inject medications, right? So it's got a thermistor, it's got all kinds of fancy stuff on here, right? So that is a Swan Ganz or a PA catheter, and that's used to measure hemodynamics.
And that's where you'll also get your mixed gases, is from your PA catheter.
Your mixed venous, so we're gonna get ours off the pump.
Well, yeah,
But that's exactly right. So that with the PA catheter, where's gonna be our most precise mixed venous measurement? Huh? No, it's gonna be in the right atrium. So what comes in there? That's the lowest, right? So the blood coming out of your coronary sinus is gonna have the lowest mixed venous. And that's simultaneously mixing with something that's coming in that's higher. So in the right atrium is where those two mix. And so that is where you get the best, most accurate mixed venous. Make sense? Okay. So yeah, we have to learn about a PA catheter. Dr. Gill hopefully will be going through that with you. You may be, you know, you go someplace, they may have you help them. So you need two people to float a swan, period. So so that cannula can get, wound up. I've had it like tickle the right, the SA node and the heart, fibrillator stop, go asystole, right? And so, they're gonna pull that back and hopefully start CPR. And so, that's the only time really where I've done CPR, because perfusion is typically we're getting our equipment ready. But if you're standing there and they start fibrillating, whoever's floating, it's sterile, so you don't have a choice. And so you start doing it until you get somebody else, and then what is the perfusionist doing? Getting the equipment ready, right? The ultimate CPR. So yeah, we got to know about a PA catheter. I'm sure Dr. Gill would go at lengths much more than what I just did. So, okay, grab something. We only got another few minutes. What is this one?
I don't know. Nobody was picking anything up, so I picked something up.
This is a vent, right? So a vent catheter is used to remove air, right? This is actually a pediatric vent. I can just tell by the size. This is inserted through, what does it say?
Left heart vent catheter, 15 French.
And so this is inserted through the right superior pulmonary vein, right? And it's floated down through the mitral valve into the LV. So a lot of times, if they're doing some type of valvular procedure, they'll just use it as a sump, be sumping volume out with it. It's also a part of our myocardial protection strategy. Right? So we're going to learn that we're going to give cardioplegia to arrest the heart. That's going to have the greatest impact, right? But also keeping the heart decompressed, right? Wall tension increases myocardial O2 consumption, so they always put in a vent for that. And so this is a left ventricular vent. This is a left ventricular vent, and it's small, so I know that this would be used on a pediatric. So you can put it in before you go on pump, right? A lot of times they'll go on pump and they'll say, fill the heart, right? And so they're asking you to fill the heart to do what? Put in the vent, put in the left ventricular vent, right? And so when you do that, they're gonna take a lever blade and they're gonna puncture the right superior pulmonary vein. If you let the volume out, you will suck air right right into the heart, and the surgeon is gonna blow up. Is gonna have gonna blow a gasket, because where's that air gonna go? To the head, right? So I prefer when they put it in before pump, but most of them, once you go on pump, and I don't know, so they can say, well, as a perfusionist, they let the volume out, but I don't know, but that's a left ventricular, and there should be another one up here that's an adult, maybe not. So that's a left ventricular vent.
How about this?
This,
Is that the new one?
yeah, so this is a cardioplegia delivery set. We see we have a heat exchanger here. This is for the MPS 3. This is the disposable set for the MPS 3. And so the question is, how in the heck do you know that? Well, because of these things, this is where you add your medications. The heat exchanger is larger.
How do you add the
I hope
medications?
that's not blood.
Ew. No, I think it's rust.
Me too. So this is a cardioplegia delivery set for the MPS 3. We have MPS 2s in the lab that we'll learn how to use.
How does the medication go in here? What do you mean?
You get like
just-
3 full of syringes.
Yeah, you're just gonna fill them. You're just gonna take a syringe and you're gonna inject it inside of here, right here. So if we take it off of here, this is gonna lead that to one of these ports, right? You'll take and put your syringe on there and you know, pump it into these, right? And so, we will have, next semester, we'll have vendors in once a week, and we will have Quest Medical come in, and they'll go through the MPS 3. It's a new device. It just came out of the market like last year. Again, we have the 2, which is very similar to the 3 in the lab, and so we'll practice using the 2.
Where did those little plastic cups?
Yeah, I know. That's what I'm
Yeah.
confused
stick to?
about.
Do they go on the heat exchanger or do they go somewhere else?
They like sit in the backside of the.
Oh, it's a
So-
whole different, you know that MPS like blue system?
You know the
the
black
lab,
system that
or
they
black,
took it
I
off
guess.
they took it off the
I think that
S5.
goes on
That's the
there.
upgraded version. And so if I showed you an MPS 2 disposable, you'd go, oh yeah, that's definitely MPS 3. It looks just like that, just slightly different. So yeah, that's an MPS 3 disposable. So this is a venous drainage cannula. And so,
Wait, it's 25 French, is that what
what
you're,
is that?
it just says Biomedicus.
Okay, it's a Biomedicus of Medtronic, right? And so this is for a femoral vein, right? And so when they put this cannula in, this is, the white portion is just a stylet, so, right, it's removable, it's just a stylet, right? It's to give it some rigidity, right, when they're inserting it. And so how this works is they're gonna put a wire in, right? They're gonna take a needle and they're gonna puncture the vein, right? And so we know how it goes, right? Lymph, vein, arterial, nerve. It's why you have to know that in the femoral triangle. They'll go ahead and stick a needle. They'll take, you know, I don't know, 18 gauge needle or something, and they'll take it, put the needle in, and then they'll put a wire into the vessel, right? And then they'll thread that wire up through the middle of the stylet, right? And then they'll also use some dilators. You might have
I
some
mean, these are
dilators.
dilators, right, but I don't know if it's for that
So
specific.
there's the needle. Right? There's the needle. This is a cannula insertion kit, I think. Biomedicus, right? So this is the insertion kit for this cannula. So it's got a needle. So it's even we got 11 blade in there, right? So you're gonna take and put that needle in, and you can take and put the wire in. You'll put the wire in through the needle, and then you'll take these dilators and you'll dilate up that vessel. And then after the last one, see it's large, and see this one's large, right? And then you'll take the dilator out, and you put the needle through this one, and you'll put this one through. And once you get it into where you want, then you'll remove the stylet, and you'll take the cap off and you hook up your venous line. So the thing about so we use these cannula a lot for mini access procedures, right? And so you're gonna have to have some type of augmented venous return with these, right? Vacuum or kinetic. What I found doing tons of mini access procedures, if you start having drainage problem, you wanna request that they make sure that the tip is in the right atrium. You want the tip in the right atrium. Remember that, it'll save you a lot of complaining. So there you go, and that's just an insertion kit. That's an insertion kit for a peripheral cannula placement.
Yeah, it's like, not this, but it's like they use blue
I
rhino.
mean, this is an RTO cam, but has the guide wire in there with it.
So this is a peripheral arterial cannula. So this is a femoral arterial cannula, although you could put it in the axillary. You could actually cannulate the axillary directly, or you could put some type of conduit on it and stick this cannula in there. If they put a conduit on your axillary, I just have them use a connector, like a 3A3 connector. But this is the femoral, so look at the femoral venous, right? And now this is a femoral arterial. And it does have an insertion kit. It's probably this right here is gonna be a needle, right? So we see a needle on there. And this is so that we can, have peripheral cannulation, so that flow is retrograde, right? So if it's cannulated femorally, the flow is retrograde, right? So they have a new femoral arterial cannula out that it flows in both directions. It's not this one. So this is a femoral arterial cannula right here. This is another one. It's just different size femoral arterial cannula.
They're kind of the same.
This is a femoral, these are just different size.
Yeah.
That's an Edwards, isn't it?
Yeah, this one is
What
this
do you-
one's a 16 French. This one's a
20.
20 French. So different size femoral arterial cannula. And this is for doing peripheral cannulation.
Did you go? Anybody else you just want me to hand you stuff?
Great.
I'll be like Vanna White.
Here's this is a retrograde. This is the global myocardial protection, right? This is a self-inflating retrograde catheter, right? So if you just say retrograde, it's going to be wrong. This is a self-inflating retrograde catheter. We have two different types: a manually inflating retrograde catheter and a self-inflating. And so we know the difference by looking at the cannula. So see that syringe in there? It's gonna go on that port, and this is a manually inflating retrograde catheter. You need to be aware of what type of retrograde catheter you have, because they function differently, right? And so if you're having issues with your retrograde coming out, well, you may need to tell the surgeon to put some more in the balloon. So they take that catheter, that syringe, put it on that port, and they'll blow that balloon up at the tip. This one, the self-inflating, when you flow through it, that balloon fills. So you need to know the difference between a self-inflating and a manually inflating retrograde catheter. So what is that? Let me have a quick look at it. And so this one would be a what?
I would say that this, without turning it over, I would say there would be a self-inflating retrograde catheter.
That's exactly right. And so what is it used for? Give cardioplegia. So all the different companies have all their different cannula styles. So we see Edwards, we see Medtronic, DLP, Medtronic bought DLP, so DLP used to sell their own stuff.
Like a balloon.
You got about 10 minutes?
This is a pop-off valve, right? One way.
Yeah, this is exactly. This is a one-way.
Lillian.
So where does this valve go?
The vents.
That's right. And so this is a one-way pressure relief valve. And so if you look on there, it'll tell you to the pump, to the heart. So it'll tell you on there. If you clamp distal to this and try to set your inclusion, you'll ruin that. It will not work any longer, You'll have to replace it, right? And so we're always gonna clamp proximal to that when we're setting our occlusions. Please remember that. When you walk clinically and you do that to your clinical instructor, they're gonna be upset.
What you guys saying?
So this is, so see that big needle in there? So this is just to put in, you know, art line. Could be a femoral art line, see that big needle in there, right? And then you're gonna, and then it's got this wire, right? And so that's just an art line, argon. Arterial catheter mini kit, right? So this is just an arterial line. And that's to measure arterial line pressure.
I mean, some of these are like the same, right? Like these are the same.
So this
Single stage.
This is a these are both dual stage venous cannula, right? And so this is for venous drainage. This is inserted where? The right atrial appendage, right? This is for cavo-atrial cannulation. And these are dual stage. Here's a stage, here's a stage. Right? They're gonna insert it to the double black line. That's how far you put it in. So these tips lie in the IVC. This stage lies in the right atrium. This is the triple stage. We can see stage 1, stage 2, stage 3. And again, we're gonna put it into the double line, but typically when you do a single stage, or a triple stage, I mean, you'll put this in more up towards the SVC, right? And so the idea is that this stage will drain the SVC, the middle stage will be in the right atrium, and the distal stage will be in the IVC. So that's a triple stage for venous drainage. This is a single stage for bicaval cannulation. This is a malleable single stage for bicaval cannulation. And so this is used whenever you're gonna access the right heart. You're gonna use it, and so it's malleable, so I can change the you know, the angle and whatnot. And so when you clamp, it does have a stylet. It's got a stylet in there, right? So that's just to make it a little bit more rigid for insertion. But you always want to clamp this space, right? This is the clamping space. You want to clamp on the wire, because once you dent that, it's not going to come back.
Is this also a single stage?
This is an arterial cannula. This is a Edwards soft flow arterial cannula, right? And so this is for central aortic cannulation right here. This little piece right here on the end, this is to tie it down. So when you set this cannula in, this little hub right here, it's movable. You can move it down. It'd never be way up there, but that's used to help. It's going to be down like this because they'll only stick it in up maybe that far, and that's used to help support that and tie it down.
How do you know that's arterial? Like, not you personally, but if you were just looking at it. What'd you say? Besides that.
So this,
Is that the only
so this
reason?
red cap, you might have that on the table. So what about if you have the red cap, right? So that's a self-venting cap. That's a self-venting cap, right? It's a special cap. This is not a normal cap. This is a self-venting cap. So when you put this cannula in, right? When you insert this cannula in, it primes itself all the way to here. It de-airs itself. And then once you get it to there, you clamp it there, and you take it off like this. You don't pull it straight off. So I was kind of struggling with it. You take it off like this, and then that'll tell you that's a 3/8. It's for a 3/8 inch line.
So that's how you.
Red
That's
cap.
how you can know.
I don't know.
You just know because you've looked at them so much. No, I'm being serious.
I bought them. I bought tons of it. I used
Okay.
to, right? So that's what type of, this is the Edwards. It's really Edwards. This is really a soft flow knockoff. The soft flow came from Terumo. So
Don't know
that's
if
an
the
arterial.
arterials have that nub where they shoot or snare down around it.
No, not all.
Not all of them. This one technically doesn't have a nub. These are all arterial, right?
No, this is a venous.
Man,
This is a venous single stage.
how do you know that?
That's by cable.
This is for bicable cannulation, right? This is for bicable cannulation when we're gonna access the right heart, we're gonna put in a single stage, right? So we want to clamp here, right? It's wire wound, right? So that it doesn't kink easy. This is a dispersion cannula. So this is, see that tip? That's a dispersion tip cannula. This is an arterial cannula with a self-priming line here and a lure lock. I hate those lure locks on the arterial line.
So when we're tested on this, are they gonna have caps?
Huh?
When we're tested on them, are they gonna have caps?
Possibly. So if you-
Are we supposed to know, like,
if you went like,
stage?
and you got one off the shelf, in a package, would it have the cap on
Yes.
there?
Okay.
So I would assume that I would leave the cap on it. But
Okay,
you know, if you
I'm
want me to,
just-
if you want me to
no,
make it
please
interesting,
do
I'll
not.
remove them. I don't know.
No.
So that's an arterial, it's actually a soft flow knockoff that's made by Edwards to compete with. So when Terumo came out with their soft flow cannula, I mean, it stole the market. And then Edwards came out with that, and then they came out with the dispersion tip, and then they came out with this tip, and it's also a soft flow kind of knockoff. And see, it's got the hub here, and this is to tie it down with your purse string suture so it doesn't get dislodged. And this one is another, I think that's the same arterial
Yeah, that's
cannula.
what
This is a femoral arterial cannula. This is a femoral arterial cannula, right? So this is gonna go peripherally. It's peripheral cannulation for flow, for retrograde flow. This is a dual stage cannula. This is an Avalon. This is so you can flow and return simultaneously. This is for VV ECMO. Right? This is actually an Avalon, very expensive cannula. Right? And so we're gonna put this tip, this portion, so it's facing the tricuspid valve. This stage, so this is where it's gonna flow. And so you see right here the arrow going in, this is where it's gonna flow. And then this is the other side, that's gonna be your drainage, and you're gonna drain from the IVC here, and you're gonna drain from the SVC here. So this is a specialty cannula. This cannula, is no lie, was probably $2,000 for the lowest one piece of plastic.
And what's the name of that one?
Avalon.
That's an Avalon, right?
Dual
Uh,
drainage.
No, it's dual lumen, so you can flow and drain the patient with that cannula. These are aortic punches, right? This is a rotating punch. This is by medical. So this is a knockoff from the clean cut. So the clean cut was the first one out as a rotating punch. See, it rotates when you twist it. So Quest Medical, they also sell the MPS. They sell the clean cut. And so what this is do an arteriotomy. So when we're doing our proximals, they'll take 11 blade and punch it. They'll stab it, and then they'll take this punch, this arteriotomy punch, and they'll take and punch it. And so that'll make a nice, clean, aortotomy for the proximal or top end of your graft. And so that's a punch that's small, it's 2.8. So a typical, a more standard size would be a 4.0, or right. So that's still very small, right? So so 4.0 is going to be 4.0 millimeters, right? And so it's tiny, right? And so think how big a vein is. Big, right? And so that is to do your proximal anastomosis. That's a rotating punch, and this is a clean cut. This is a knockoff from this clean cut from Quest. So these are all punches. So adult practice is going to be more of the 4.0, 4.5. They have different size punches. This is a small one, 2.8. So Time to go?
Probably. Depends how long.
Do we,
Takes
do
you to
we,
get
do we
code.
wanna pick this up?
What do you
Sure,
mean,
there's
like,
not much left.
like,
Everybody know what these guys
We
are?
can pick it up next time or something.
Yeah.
Yeah. Alright, corn boards.
You wanna pick it up next time? Go
Start
through
again
everything?
next one.
And so, does everybody knows what those are?
Arm boards.
Oh, wait.
Yeah, on boards for an
Yeah,
art
I'm sure,
line.
I'm sure you know, I'm sure you know. So.
Yeah, we can help them. We can help
They
them.
probably don't know.
Yeah, we can help them.
Right, so, again, anything that you see in the lab that you don't know what it is, bring it here to class, bring it to the class, let's talk about it, right? Okay? So a lot of stuff, right? And so you need to know that language, so you're speaking the right
Wait,
language.
what did you say? Thinking somebody's what?